Hi, this is Dr. Jessica Spies. I'm a dermatopathologist here at CTA Pathology in Portland, Oregon. And we're continuing to go over the lever chapters for you. And this is the most recent edition of lever that we've been following, excuse me. And this is chapter 19, Inflammatory Diseases of the Nail. So inflammatory processes of the nail, just a few comments. A large number of skin diseases can also affect the nails. Most of the clinical changes are not specific to the disease. Nail unit biopsy rarely is the way to diagnosis, but indicated in rare instances, and for example, nail unit lichen planus. Today's lecture will not be an exhaustive list of all the diseases that affect the nails. It will also not be an exhaustive list of all the myriad clinical findings in the diseases that I do mention. Rather, I'm going to follow the lever chapter and what its editors thought it was pertinent to cover. You will likely have very few nail pathology questions on your boards, and those that will be there should be classic examples of nail pathology. So a few caveats about nail pathology. Nail unit sampling technique is an important component of nail disease diagnosis. The hard keratin of the nail plate complicates the biopsy procedure and the specimen submission and processing of the biopsy. Biopsies are often misembedded or partially destroyed in histology labs that are not used to processing nail specimens. Here at CTA, we're lucky enough to work closely with Dr. Phoebe Rich, who's an internationally known dermatologist who specializes in nail disease. So we get a large number of nail biopsies and have specially trained technicians in our lab to handle them. So all of these limitations can affect the quality of the sections available for interpretation by the pathologist. I just wanted to show a picture of the nail apparatus before we started. And here we have what you see in your clinic, the free edge of the nail, the body of the nail, the lateral nail folds, the lunula, and the eponychium. And here's a cross-section of the finger, and you can see here we've got the hyponychium, which is just underneath the free edge of the nail, the nail bed underneath the body of the nail or the nail plate. At the proximal end, the nail matrix, which is what makes the nail plate, and the nail plate grows out over and attaches to the nail bed this way. Here we've got the proximal nail fold and the eponychium or the cuticle. And then of course, underneath the nail bed will be the onychodermis, and then underneath that, of course, the soft tissues and the phalanx or the bone of the fingertip. Here's what it looks like under the microscope. And this actually image is flipped from the last one. But you can see here, we've got the proximal nail fold. Looks like an isthmus coming out here. A little bit of the cuticle. And then here's the nail matrix that makes the nail plate that sits on top of the nail bed. And then here is the onychodermis. What we saw here in the last diagram here, the lunula is the distal matrix, and everything distal to that, that's more pink colored in this diagram, is nail bed beneath the nail plate. All right. So inflammatory processes of the nails, they mainly affect the matrix, the nail bed, the hyponychium, and the nail fold. Nail plate changes are mostly secondary. Matrix diseases can lead to irreversible damage of the nail plate, and that's important to know because you want to get things early in terms of treatment. Nail bed and hyponychium processes that do not affect plate formation can still affect the nail plate shape and or adhesiveness. When you get nail bed injury, it causes a switch from onycholemmal keratinization to epidermoid keratinization. So from the specialized nail keratinization to more of what you see in the skin. And that process is known as metaplasia. So then you get the products of the epidermoid keratinization build up between the bed and the plate, and this causes the shape changes that we see in diseased nails. And it can also cause shedding, and we see this in psoriasis and onychomycosis, for example. Nail fold involvement, the ventral surface of the proximal nail fold. When it's inflamed, it can lead to cuticle inflammation and changes in dorsal nail plate. So one of the most common inflammatory processes to affect the nail is the nail unit, eczematous dermatitis. Atopic dermatitis is the most common. You need to know that contact dermatitis can affect all of the nail unit areas. Nail plate changes usually result from matrix or proximal nail fold inflammation. And you can get onycholysis when you have involvement of the distal hyponychium, which will spread proximally from the tip of the free edge of the nail into the nail bed. And then you can get an eczematous dermatitis secondary perinechial infection. And if you biopsy this, you should be focused on the areas of involvement. And really, in general, you do not need to biopsy an eczematous dermatitis involving the nail. You don't need to biopsy the nail. You really just, if you don't know what it is, you can biopsy the adjacent skin. And in the skin, you're going to see spongiosis, epidermal acanthosis, and always do a PAS for fungus. It can perfectly mimic eczematous dermatitis. Here is the H&E of, this is of skin, not of nail bed or nail matrix. But here's dyshydrotic eczema. You get this huge amount of spongiosis with these large vesicles, spongiotic vesicles in the epidermis. Here's a little bit closer look at a more muted spongiosis, but this is, you still have epidermal acanthosis, spongiosis, and lymphocytes and or eosinophils, usually both, in the subjacent dermis. Here's a clinical of an eczematous dermatitis. You can see involving the skin around the nail and then causing lateral ridging in the nail, which is not specific to eczematous dermatitis, but it's common. Probably the next most common inflammatory disease that affects the nail is psoriasis of the nail unit. Psoriasis occurs in up to 50% of psoriasis patients and 80%, so it's more common in patients with psoriatic arthritis. It can involve any part of the nail unit. And if you have to biopsy it, it's best to biopsy through the nail plate and the nail bed, because that's usually where you're going to find the pathology. As in cutaneous biopsies, you must rule out a fungal infection with a PAS stain. Psoriasis and fungal infection can have the same histology. When you get proximal nail matrix involvement, you get pitting and roughening of the nail, and the histology that corresponds to that is parakeratosis on the outgoing plate surface. So kind of on top of the nail plate, you get this parakeratosis that as it grows out from underneath the cuticle, it sheds and it leaves these pits in the surface of the nail. If you have involvement of the mid and distal matrix, you get leukonychia or white nails. And that histology, it corresponds to histology of a parakeratosis in the body of the plate, a little bit deeper. If you have nail bed involvement in psoriasis, you get onycholysis, which is separation of the nail bed and nail plate, and that causes a white-yellow discoloration usually. You can also get, and this is prototypical for psoriasis, the oil drop or salmon patch sign, and that's a yellow-red discoloration proximal to the area of onycholysis in the nail. And then I have an example from our case file to show you on the Philips slide scanner. This is an example of psoriasis in the nail bed. And you can see here, Let me orient you a little bit. Here is the nail plate. You can see underneath the nail plate is all of this hyperkeratosis. There's even a little bit of bacteria that's colonized this area. Not a lot of parakeratosis, but you can see a lot of parakeratosis. Here are some, these purple shapes here are parakeratotic nuclei. And then here is the nail bed, and you can see here, even in our lab, it didn't get completely well oriented. This is a tangential sectioning of the bed, but you can still see here, let me turn it a little bit. Here's the surface of the bed. We've got this parakeratosis. We've got inflammatory cells. These are neutrophils here in the parakeratosis. And then we've got epidermal acanthosis, a little tiny bit of spongiosis, but this is not a spongiotic dermatitis. This is psoriasis. And the clue really is all of these neutrophils here. So then some clinical photos. Here's psoriasis of the nail with multiple findings in one nail. You've got the onycholysis, or the separation of the plate from the bed. You've got proximal to the onycholysis, the oil drop sign or salmon patch sign. And then you also have the pits. Okay, the next disease that's commonly seen, well, out of all the inflammatory processes that affects the nail, aside from infection, which we'll get to, lichen planus of the nail. And this could definitely be a board's question. The incidence is 1 to 10%, lichen planus of the nail in patients with disseminated LP. It may develop in the absence of cutaneous LP, and that's when it's going to be important to biopsy the nail. Fingernails are more often involved than toenails. When the proximal matrix is involved, you get longitudinal grooves and ridges, and that's called onychorexis. The histology, just like cutaneous LP, if you biopsy it, you see hyperkeratosis, hypergranulosis, vacuolar degeneration, necrotic keratinocytes, and even colloid bodies at the dermal epidermal junction, and a band-like infiltrative lymphocytes, and often histiocytes with occasional melanophages. You may get hyperpigmentation in the nail, and all of this may be reversible if it's treated before scar formation, but this is a scarring process in the nail. So it's important to catch it early if you can. If you have diffuse nail matrix involvement, you get onychoschizia, which are lamellar changes, and you get fragile and brittle nails. In the very late stage, in the scarring stage, you get pterygium, and that's when the proximal nail fold and the nail bed get fused together by scar formation. When the nail bed only is involved, you get proximal onycholysis with an otherwise normal nail plate. And this is a very different, presentation from the distal onycholysis that you get in psoriasis. You can also get papular lesions of lichen planus in the nail bed, and you get focal atrophy of the bed that leads to spooned nails or koilonychia. Another finding you can find in LP is shedding of the whole nail plate due to diffuse nail bed involvement. So here is an example of the onychorexis, the longitudinal grooves and ridges due to proximal nail matrix involvement in lichen planus. Here's the late stage of LP when there's been scar formation, and this is called a pterygium. And then here, just a little reminder of what LP looks like histologically. You have a lichenoid reaction pattern or a band-like infiltrate of lymphocytes, sometimes of histiocytes and melanophages in the dermis. And then You get this sawtooth or jagged reedy ridge formation with colloid bodies, these pink globs here are colloid bodies. And you can also often see individually necrotic keratinocytes are probably are tucked in here, hard to see in this picture. And you also get hypergranulosis. So you can see, this is actually a lichen planus of the skin, but you can see all of this in the nail. And it may be a little bit more muted. You may not have as much epidermal acanthosis, not as much hypergranulosis, not as much inflammation, but you'll still see the same features. Connective tissue disease can affect the nail. And most connective tissue disease does. Usually the microvasculature that's affected, and as all of you know already, probably, you get dilated capillary loops, hemorrhage, avascularity. Lever talks about PASD, positive material in keratin of the cuticle. I will tell you that we almost never see biopsies of connective tissue disease in the nail, and so I can't verify that for you. But they do talk about that. I doubt that's going to be a board's question. And you can see this identical feature in Raynaud phenomenon, and it's not really known if nail unit biopsy distinguishes between Raynaud's and connective tissue disease. Lupus of the nail bed, we had an example in our file, so I wanted to talk about that. Discoid lupus can occur in the nail, but it's never localized to it, so a nail biopsy is rarely needed. It can cause nail dystrophy and longitudinal ridging. Hypertrophic LE likewise can cause hyperkeratosis in the nail bed, and you get longitudinal ridging from that. Systemic LE, you get a wide range of nail abnormalities that are not specific to the disease. And the histology is similar to that of cutaneous lupus. You get an interface dermatitis with squamatization of the basalis, a lymphocytic infiltrate, occasional melanophages. And we do have this example in our files. I'm sure this came from Dr. Rich. And I actually don't know where this from. We don't have nail plate here, so maybe this is proximal nail fold from the shape of it. It's hard to say. But you can see we've got hyperkeratosis, some hypergranulosis, even kind of a little bit like LP. We even have some colloid bodies here. Lymphocytic inflammation, we should have some kind of smudging of the basement membrane zone. That's prototypical for collagen vascular disease, especially lupus, some occasionally necrotic keratinocytes. There is some very mild spongiosis, but this is not a spongiotic dermatitis. And then some melanophages here. Next slide. Lever also delves a little bit into bullous diseases of the nail. And the histology is similar to that in cutaneous disease if you biopsy nails in these diseases. And Lever mentions Derrier-White or Derrier's disease. Nail involvement most often occurs in association with other clinical findings. The histology is, as in cutaneous disease, intraepidermal acantholysis with dyskeratosis or acantholytic dyskeratosis. If you have nail matrix involvement, you get a white streak in the distal lunula. If you get nail bed and hyponychium involvement, you get red and white longitudinal streaks. Pemphigus vulgaris and foliaceus can also affect the nail unit, but it is very uncommon. It's usually only in severe disease that the nail unit is affected. Proximal and lateral nail fold involvement leads to chronic paronychia. The histology, similar to that seen in the skin, is suprabasilar acantholysis, and if you do a direct immunofluorescence study, you get the deposition of intercellular IgG and C3. If you have matrix involvement, you can get onychomatosis, which is proximal separation of the nail plate. Other bullous diseases reported to involve the nail unit include pemphigoid, EM, TEN, and EBA. Here's an example of Darier's disease with the red and white longitudinal streaks. Here's a nice example here. This is a little bit later stage. And this is not specific for Darier's disease, but this V-shaped nick at the edge, the free edge of the nail is suggestive. You can see it in other diseases. Here's the histology of Darier's disease. You get intraepidermal acantholysis. So here we've got an acanthotic epidermis with all of these, keratinocytes that look like they're floating. They are becoming unattached from their neighbors. Here, a little bit more acantholysis. And in this example, you can see the core ronds and the core grains, which are typical of the acantholytic dyskeratotic diseases, Darier's being one of them. And the grains are these kind of perikeratotic nuclei in the perikeratosis, flattened purple nuclei. And the ronds are the dyskeratotic cells that are kind of halfway between an acantholytic cell and a grain, and they're still round, as in rond. It's a core rond or a round body. And all right. Here are some clinical examples of pemphigus vulgaris, excuse me. You have the paronychia and the onychomedisis, which is the proximal nail plate separation, which you can see here, I think a little bit appreciated in these photos. Here's what pemphigus looks like under the microscope. You get acantholysis, but not usually very much dyskeratosis like you see in Darier's disease. And you have these characteristic tombstones, these dermal papilla covered by a thin layer of keratinocytes that are still intact, with everything above them being having come unmoored from their neighbors. Here is the DIF study. This is a really beautiful example of intercellular IgG and C3 being deposited between the keratinocytes. Okay. Next, I wanted to talk about nail infections, starting with onychomycosis. Dermatophytes are the most common cause of onychomycosis, with 2 species causing over half of the infections, Trichophyton rubrum and Trichophyton mentagrophytes. I'm not sure how to say that. Molds can also cause onychomycosis, and these are the 3 species that are most common: Acremonium, Fusarium, and Scapulariopsis species. Yeast can also cause onychomycosis, mainly Candida species, and especially Candida parasilosis. In toenail infections, 90% of them are either Trichophyton species, Macrosporum species, or Epidermophyton species. By contrast, in fingernail infections, Candida or yeast infection is much more common. Up to a third are due to yeast. Clinically, nail infections in onychomycosis, there are 4 main types. The first is the distal subungual. It's the most common. It's usually T. rubrum. It first involves the hyponychium in lateral folds, out at kind of around the tip and the sides of the nail. And it causes, as it invades into underneath the nail bed, it causes yellowing, onycholysis, and eventual subungual hyperkeratosis. The second type is the proximal white subungual, and that is very rare in the general population. However, it is common in HIV patients, and it's also caused by T. rubrum. The third type is superficial white, and it's usually caused by T. mentagrophytes. except in HIV, it's usually T. rubrum. The fourth type of clinical onychomycosis is candidal. And this is a common cause of chronic paronychia. It may involve the plate and the bed in chronic mucocandidiasis in HIV patients. And it can be particularly striking in pediatric HIV patients. So it's when it is this extensive, it's usually a sign of immunosuppression. Here's an example of fungal, or the most common type of onychomycosis. Here is an example of proximal white subungual onychomycosis. Here's an example of the superficial white onychomycosis. You can see it has a much whiter appearance. Here is an example of candidal onychomycosis and paronychia. So you've got the paronychia here, and the proximal nail fold, and then the candida infection undermining the nail and the lateral nail fold. So for the diagnosis of onychomycosis, a biopsy with PAS staining is the most sensitive, a nail clipping. It has a sensitivity of 99%. It also has the highest negative predictive value. When you do get a nail sample, make sure to sample the subungual debris. It is by far the highest yield to identify the fungus in the subungual debris. The PAS will highlight dermatophytes, yeast, and mold, but it cannot distinguish between these organisms. You need another method for that, which I'm sure all of you have done in clinic already, is KOH with chlorazole black. That is also a fairly sensitive method of diagnosing onychomycosis, and it is certainly the most cost-effective test. Culture is much less sensitive than either PAS staining or KOH, but it will identify the organism, which the PAS and KOH cannot, in terms of whether it's a dermatophyte, yeast, or mold, and which particular dermatophyte, yeast, or mold it is. However, now, the newest technology to identify organisms, which we're very excited about here at CTA because we see a lot of nails, is PCR. And we've just gotten that up and running in our lab. It's currently the most accurate method for identifying infectious agents in nails. It's far superior to culture and highly concordant with the PAS stain. So we're starting to do it as a reflex test on PAS positive nails. So I have one example in our file of hold on a second, it's D, onychomycosis. I think this first one is the best. Here we've got the H&E stained nail, and you can see the nail's a little bit thickened. Oh my goodness, you can even see the, wow, this is a little bit unusual. I think you can see the organisms on the H&E, these clear spaces that are kind of wavy. And this even looks like a yeast form here. You can get some artifactual separation in nail plates, so you definitely need the PAS to identify those as dermatophyte, mold, or yeast. And here's the PAS stain, and you can see in that same area, we've got this hot pink, these hot pink hyphae. And some of them even look septate here. I wanted to talk a little bit about onychomycosis due to mold. It can happen in healthy or immunocompromised patients. It can co-infect with dermatophytes, both in the nail and in the skin. It cannot be distinguished from a dermatophyte on a PAS or KOH stain. And it may be thought to be a contaminant when you send it for culture and left out of the culture report, because some molds are very ubiquitous, such as aspergillus, in the environment, and so they can be thought to be contaminants. So this is part of the reason that we have the PCR up and running in our lab now. The PCL will report a very large number of dermatophytes, or look for a very large number of dermatophytes and molds and yeast. The one thing that it won't report on the system that we have is aspergillus. It's too ubiquitous in the environment, as I just said. And so that is a little bit of a diagnosis of exclusion right now. Because onychomycosis due to mold can be difficult to treat, think about it in treatment-resistant onychomycosis. I did want to also mention that culture of molds is identical to that of dermatophytes, except that there's an antiseptic actidione, which is the same thing as cyclohexamide, is left out of the medium. So if you're going to send something for culture, you want to say that you're specifically looking for mold. However, I highly recommend that you do the PCR. It's much more sensitive. So here I have an example of a report on a PAS positive nail. This is an example from our lab. And these are all the dermatophytes, molds, and yeast. It means you got Candida albicans is down here that we look for. And here are the plates. And we just got this up and running, so I haven't seen any of these in person yet. These are our test cases, but we're going to start doing these on regular nail samples. So lastly, bacterial infections of the nails. Bacteria can cause chronic paronychia in the nail folds, Staph aureus, Pseudomonas aeruginosa, and those bacteria co-infected with Candida are the most common actors. And then, of course, I'm sure this will be a board's test and everybody will get it, but the green nails of Pseudomonas are Pseudomonas colonizing oncolytic or damaged nail plates. What causes the green color is piocyanin pigment made by the bacteria. Pseudomonas loves wet environments. Pseudomonas also causes, as you may remember, swimmer's ear and hot tub folliculitis. And so it can colonize gaps between the natural and artificial nail under artificial nails. It can also cause onychomycosis in people that have prolonged exposure to water or soaps. And it can cause onychomycosis in periungual trauma, and can extend from a chronic paronychia. And here's an example of the green Pseudomonas nails. Okay, so that's it. It was a short chapter and kind of an introduction to inflammatory disease of the nail. I hope you enjoyed it, and we'll see you next week.